What just happened? All right. So, welcome to NUR203 exam 2. As you all know, that this exam, they are different in all the classes, but to tell you, they're not different. The questions are the same concepts that are asked differently. That's the only difference in them. So anybody who listens to this on YouTube, which many do, know that this is not a waste of your time listening to me. You don't have to go to your own professor. I always tell you to go to your professor because you're used to their teaching style and then listen to someone else. If it's me, I explain things simply. Professor Morris tends to go into detail. She's more, reads down it and makes comments about it. We're born on the same day of the same year, 6 hours apart. So we're both so OCD and making sure our students get what they need. So let's go. Exam 2 is week 4, 5, and 6. I took a bunch of pictures, put them on there. I think they really say a lot of words. So we know that one of the first things that we were studying in this week was all about cognitive and sensory impairments. Now, cognitive, we'll go into, but sensory is how you hear and how you see. So, disorders of the eyes. Amblyopia, if you look at the picture, that little eye is turned in. And what it is that muscle is weakened. So one of the things we need to do is make that weak muscle work. Just like if you had a weak ankle that you injured, you are going to make sure that we do something to help it. Now, and it's first letting it heal and then exercising if you need it. Now, this one, we're going to put a patch over the good eye and make that bad eye work. And it's going to strengthen those muscles. So that's amblyopia, lazy eye. Now, strabismus is very similar to the newborn's vision, that binocularity, where both eyes sort of work like in unison, not together, and they sort of cross over. So it's like a cross-eyed, but it's because they can't focus on it. All right. So that's the strabismus is that the eyes go over each other. All right. And you could call it cross-eyed if that helps you. Now, cognitive development. Cognitive development, we know that there are developmental milestones that we check on every children. We look at, of course, what they look like. That's one of the things that we can see with those syndromes that are cognitive delays. You'll see those dysmorphic syndromes. They look different. They could have the different eyes, different tongues, the nose, the bridge is different, ears, jaws, all different things can look different. But then we get into those developmental milestones. Well, they're irritable for no apparent reason. Because why? They can't express themselves. So they get irritable and frustrated because you don't know what they want. They also tend to like block out everything around them. So they don't get any response. You can call their name and they're really not going to answer you. You'll see gross motor delays. They won't be walking by 1 year old. They won't be turning over sometimes by 6 months. They won't be sitting up unsupported by 8 months. It could be 12 months sitting, depending on the level of cognitive impairment. Language problems, they should be saying mommy or daddy, right? Everybody looks for that the first year. Well, they may not be able to do that. And in that behavior difficulty is like that irritability, okay? That means I can't express myself. You don't know what I want, and I can't tell you. Depending, I mean, it doesn't have to be in the first year. It could be in the second or third year. They just can't. So I'd be frustrated if I couldn't either. And of course, those normal milestones, that fine motor, that reflex grip, palmar grasp, and then it becomes that voluntary. They're just not going to do it in the same time frames. And that's your fine motor, because fine is fingers. And the gross motor is the get up and go, 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 the rolling over, the sitting up, the walking. All of them are delayed. Now, Down syndrome is one of those syndromes that you think of when you're talking about cognitive delays. We know that, there are all different sort of Down syndrome. Everybody thinks there's one. There's actually, just for your information, 21, 18, 15, 11, and 9. And you don't have to know those numbers, but for your future, if you want to work in peds, just know that 9 is the most severe with the most severe problems to them. 21 and 18 are the most trainable, but they all sort of look the same. They're stubby, short fingers and toes. We got a different way of the arch up than the palate, so it's more difficult to feed. The tongue is always sticking out. They've got those almond-shaped eyes. They're very flexible. They can literally put their both feet over their head, right? It's just amazing. Just be careful because those hip joints can pop out. You might see that. Another thing is Down syndrome. Somebody is on, let me get the mute. There it is. I got it. All right. Sometimes when we have Down syndrome, one of the things you need to be aware of is there is cardiac defects known with it. Cardiac defects and a higher possibility of leukemia and hypothyroidism. Those three things need to be looked at birth, and leukemia as they grow, those checkups, checking the thyroid levels as they grow up. And cardiac defects, most common would be just a simple ventricular septal defect, but it could go into more complex. They do have that semian crease, that little crease across their palms and across the soles of their feet. We can see those things. There's that big toe and the second toe. There's that big space between them. And then they have this nasal bone that's flat. And it's called an underdeveloped nasal bone. And it sort of holds mucus, traps it there. So it drips and it causes a lot of upper respiratory infections. Cognitive children in general, they have extreme high anxiety when they're separated from parents. So if you notice in the italic size, very important that these parents are allowed to stay with their children. It will help decrease anxiety and stress, and the child will have a better time. They don't understand even like a normal toddler or preschooler or even school age child. Mom needs to be there. Now, autism is another cognitive delay. It is usually not diagnosed till age 2 or 3. We'll see the signs and symptoms up to there, but usually that final diagnosis isn't given till then. These children don't look in your eyes like normal children would. They're not gonna, again, like decrease response to their name. These one absolutely don't. They're going to be in the corner playing in their world and they're not going to listen to you. They're not the type that you stick your tongue out as an infant that they'll stick it back, or they'll see other children put blocks on top of each other, imitating those things, or hands up, hands down. They're just not going to do those imitations like every other, the child, quote, normal child that doesn't have cognitive delay would be. They're going to have verbal and fine motor delays. So they're not going to be doing that little pincer grasp by 10 months. They're just not. It might be later on into 1 year or more, or year and a half. Also, verbally, they don't talk. They're more like grunting at first. They may not say words till 2 years old. Again, behavior difficulties, just like the Downs child, cognitive delay, they can't express themselves. They don't know what they want. They don't know what they're thinking. And these children, even more with behavior difficulties. They like to play alone. They don't like to be around people. They don't like loud noises. And these are the children that sometimes you put foods in the mouth, they don't like the way they taste. It's too moist, it's too chunky. They have this aversion, it's called. And as I said, it's usually ages 2 to 3. And one of the things about autistic children, because they don't have any common sense on them, be very careful when planning activities, giving them toys. Remember safety. Safety is key with these children. So verbal milestones. By 2 months, they should be saying, one single sound. Usually they start, making ah, ah, ah sounds at you. By 3, 4, they're cooing and gurgling and laughing. And by 8 months, they're imitating. That's when you start saying Nana, 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 if you want your name, or Mommy, Mommy. By 10 months, they are understanding when you say, no, don't do that. Come over here now. And they do understand. By 10 months, mommy or daddy should be said. And up to 1 year old, maybe 3 to 5 different words. They might say they want milk or they want juice or they want mommy, daddy, whatever it is. They can start telling you different things. So one of the things about children that if they are being spoken to or there's loud noises and they're not making responses to them, always remember speech and hearing are connected. If they're not speaking correctly, they should be put for a hearing evaluation. They might need speech, they might need hearing aids. You don't know. So again, if they don't, respond to sounds or they're not understanding, it could be they're not hearing. So hearing should be evaluated. Now, children in the hospital, you do get kids that get really ill and that are in the hospital for months at a time. And you don't think just adults get bed sores and foot drops. Children can get all of these things too. So, good nutrition is important. I mean, this is why we'll tube feed children and have them on hyper-al and tube feeding. We want them to get all the nutrition they can. Using a draw sheet, you don't want to just scooch them up on the sheet because it will rip their skin off. Their skin does get brittle. Keeping them dry with either that Chuck's pad or a diaper, very important. Turning them and then using things, soft egg crate mattresses or beds or whatnot to turn them. It reduces a lot of that pressure and it does help. And they do get these pressure ulcers. So making sure that turning and rubbing lotion on them and foot drop would be just making sure that we're exercising those legs, a passive range of motion type stuff. So being able to assess a child can be quite difficult, and we've learned that through, looking at infants and toddlers and preschoolers. Now, to get a really good, accurate assessment, number one, always remember to get on their level. Make you not so threatening. So, we're going to sit down, I like to sit below them, not equal. I usually go below, and then I'll just start with an older kid saying, oh, you've got cute little cheeks, or start to tickle them or peekaboo or whatever it is. Give them a sticker. All right, now I got them. So now they're comfortable. Now they're sitting on mom's lap. What's the best thing to do when they're doing that? That's when they're comfortable, they're happy. I'm going to listen to breast sounds and heart sounds. There's an infant asleep in mom's arms. I'm going to do breast sounds, heart sounds. That will work well. Remember, it is not head to toe when it comes to children. In the hospital, children, keeping them on the same routines, nap time, bath time, bedtime, what they eat if you can, if it's allowed on their diets, try to keep that same routine. And number one decreaser of stress, especially when toddlers are involved, is allow the parents to stay with the child as much possible because separation anxiety, right? We've learned about that. Separation from parents is the greatest source of stress. Now, there's ways that we can find out how children are feeling. A lot of children, you don't know why they're afraid, but they can sort of reenact an experience and it can tell you what's going on, or they can get out their frustrations, right? So, expressive activities is a way that you can have them just release their frustration. Maybe it is taking a piece of clay and pounding it or squeezing it, throwing a ball, using bing bags and throwing it against the wall. I've done all sorts of crazy things with children, and it really does help. Dramatic play would be when you have a kid, something's happened, and all of a sudden you see them withdraw a little bit. They just had a procedure. They can't tell you what happened, but let them reenact it. Let them get a teddy bear, a doll, or whatever, and let them show what went on during that experience and where they said owie or ouchie, right? And then those creative expressions by drawing and painting, again, they're expressing themselves. How they're feeling inside is what kids do paint and color with. So one of the things about children is pain. Many years ago, we didn't really address pain as good as we should have. And children are not going to do things if they're in pain. So, number one, if you know a child just had surgery, make sure that we are medicating them, making sure that they get their pain medicine. Children post-operatively are going to have respiratory complications. They can, and atelectasis, and filling up fluid in the lungs, or they can have thrombosis in the legs. Children can do too. So a kid's not going to cough. Deep breathe, use incentive spirometry, get out of bed, walk, do what they need to do unless they're medicated, right? So you can't, I mean, I wouldn't even reposition a child who's just had some sort of surgery. Maybe it's an appendectomy. Maybe it was cardiac surgery. I mean, their children do have a lot of surgery. So repositioning them, turning them can hurt. Remember that. Distraction is amazing. Turn on music and start dancing around and doing things with these children. They forget they're in pain. And do deep breaths and make it a game, make it fun, and it really helps. Okay. If you have to leave the room, leave them with a crayon and coloring books, depending on the ages of these children. Give them something to keep it off their mind if they hurt. Some cartoons on TV, whatever it is, all those things really, really work. One of the things with children is you need to tell them if something's going to hurt. Now, you can tell them if they ask if it's going to hurt, you can say, yeah, it's going to hurt a little bit, but I'm going to do everything I can to help make it as little as possible. But if they don't ask, they're probably wondering. I would tell them anyway. Say, it's going to hurt a little bit, but I'll go hold your hand really tight. You can squeeze my hand if it hurts a little bit, and no, it's not going to be pain for that long. Okay? These things do help. We forget that there's Tylenol and there's ibuprofen for children. Those things work really good in the younger kids. Um, Morphine, and then in between, we can give acetaminophen, ibuprofen. They work well, okay? And that, again, with using the opioids, using these, positioning, ice packs, cold packs, head up, head down, all of those things together can help. One of the things that we should always let our parents know is never, ever, ever to give aspirin. Aspirin can cause Rey syndrome, and that can cause a lot of big problems in a very sick child. And ibuprofen cannot be given until they're 6 months old. There's something with platelet aggregation, coagulopathy that has to do with ibuprofen earlier than that. So only acetaminophen for the first 6 months. So IV sites, we should check it every hour. 10 mLs in a small baby's hand could be a lot of fluid, could be like 100 mLs for us. So what are we looking for? Swelling, redness, pain, streaks, blood, or just leakage around it. And any of those things you see, stop it immediately. And then I like get elevate their extremity. If it's something that's caustic, we might have to do some, put some medicine in there, that Regitine type thing that increases circulation to help prevent necrosis of the tissues. But and I also put warm packs on them and get it out. Start another one. These IVs can cause a lot of problems. I've seen hands, feet, heads turn black and big scabs happen with IV infiltrate. So first thing, get it out. Stop it. Oxygen is something that we give a lot of infants. You have newborns born that came out with what we call TTN, transient tachypnea of the newborn, TTN, and they need a little oxygen, they need a little help, or they're just premature and they need a little help, they need a breathing tube. So, what is the best that we can give these children that's easiest tolerated and extremely accurate? That's the oxy hood. Look at that little baby looking around. They can suck their fingers. They can suck a pacifier. In infants, we don't necessarily have to do a blood stick and anti-cube for blood. We can do a heel stick, but there's some things we need to remember. Number one, we need to warm up the area with only a hospital-approved heel warmer. If you take a washcloth with hot water or heat it up in a microwave, infants burn very easily. So only hospital-approved heel warmer, okay? We need to stick the sides of the heels because the back of it is a calcaneus bone. And if we use a lancet that's too big for them, it could hit that bone. Then you have osteomyelitis, right? And another thing with infants that we do is we do not do bag urines on infants that come in with a possible fever, possible urinary tract infection. We will do a straight cath. And the reason is infants are their immune systems are weak. We really need to get an accurate understanding of what organism is there. And with that, we do the cath, we put them on an antibiotic, check that culture, and make sure that they're on the right one the first round, or they're going to keep getting these urinary tract infections. Now, stress and hospitalized child. Now, if you're a kid who just comes in and out once, you're actually not going to have as much stress as that child who maybe is a cardiac child who keeps going in. Or how about a cystic fibrosis child? Or what about a child with sickle cell? Those children are in and out of the hospital. So those children are going to have higher stress, the ones that are in there more. One of, again, separation anxiety. Biggest stressor is when parents have to leave. So again, make sure that parents stay in the room. Of course, following their schedule is important. We find that the male child is more difficult than actually the female at the younger ages. And we know cognitive impairment makes a difference, and they do need their parents there during hospitalization. Now, we talk about young children and regression, and usually it's a response to hospitalization. It could be that the parents had to leave or they in and out because they have to run home quick or, just switch with mom and dad and all those things that go on. And all of a sudden, you're going to see those children regress. So, what do you see? Well, some children who are potty trained are all of a sudden are going to be incontinent or they're going to refuse to go to the bathroom. Some of the children who are sleeping all night aren't. Some of the children, start calling out and need more attention. And it's because they want to feel safe. They want to know somebody's there. The infants, toddlers, and preschoolers who usually can sit there, play by themselves, toys, whatever. Now they're not, and they need more help. This is where you'll have the same nurses there every day if you possibly can, instead of switching them out. Because we know the younger kids will have more separation anxiety and also those cognitive delays. Now, one of the things with children is allowing them to touch things, letting them play with equipment. Today we have Child Life today, and we know that those people come in and let them touch and feel and see everything about it. So again, letting them touch the equipment, explaining things won't hurt, and again, how many times can I say separation from parents is the big thing. Now, school age children, usually do better with the routine. They like that structure, and that gives them comfort. A school-age child is actually tolerates better a parent not being there because they understand it more and they can verbalize and express themselves. Now, family-centered care is what we want to know what they're doing every day. We want them to be a part of the care if they're there, but we're always concerned. It's always about safety, making sure they don't leave side rails down, that they put crib rails up, that they don't leave children unattended laying on surfaces that shouldn't be. All of those things are really, really important until we know the parent's going to do that. Remember, they're in our care, okay? Now, otitis media is something that has to do with children, and I think all the kids get these things. It is bacterial, and it's because children have narrower, shorter, and the eustachian tubes are more wide open. Priority care. Now, if you have pain in the ear, you can almost be guaranteed it's otitis media. We know there's an infection. So you would say priority care would be antibiotics. No, it's not. Your priority is let's take care of that pain. Pain is always number one. And acetaminophen works just fine, as I said before. Now, it's going to take 2 days or 3 days for the antibiotics to start working a lot. So we will put antibiotic drops in if the child is having externa, which is the outside ear. Sometimes with ruptured eardrums, I just had one in January. They put drops in, and we had oral antibiotics too. Remember, it's a staph infection, so things like Augmentin are great for this one. These children with chronic ear infections may need to have tubes. And one of the things with children in otitis media is that we need to do everything possible to prevent ear infections. Actually, smoking in the house causes ear infection in young children. So as nurses, washing our hands, teaching parents, washing their hands, using the sanitizer. And another thing that can help is those immunizations. A lot of those immunizations help prevent upper respiratory things, mucus going into the ears, ear infections, because we want to decrease the amount of ear infections in children. Now, bronchitis. We have upper respiratory. We have bronchitis, the bronchioles. We have tracheal bronchitis, which is more upper, which is more croup. And then, we have the bronchitis, which is it's irritating. It's a dry, non-productive hacking cough. And when you try to go to sleep at night, you can't. Why? You're coughing, 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 coughing. Most of the time, you don't have a fever. Most of the time. And we just treat the symptoms here. If you have a fever, which is unusual, of course, you'd be taking your acetaminophen or your ibuprofen, but it's really the cough medicine that we would use for this child. Now, croup is laryngeal tracheal bronchitis. So this is all upper. And this is the larynx, gets a little swollen here. And this child, the common croup, is going to bark like no other cough you've ever heard before. Sounds like a seal, and it really does. Remember, if this, it's most likely it's a virus. I mean, it's common. Very rarely have I even seen it treated as a bacterial. It's usually RSV or flu or just a upper respiratory. And then it swells up the little bit of larynx back there, causes inspiratory stridor, because the upper airway swells, the air can't get in. And what happens is we'll give a steroid for this, some type of steroid. Cystic fibrosis. This is a recessive inherited gene. Remember, both parents must have the gene, and then you have a 1 in 4 chance or 25% chance of having the disease. One of the signs and symptoms of cystic fibrosis is a meconium ileus, which means no stool for the first 2 days of life, this is one of the things they'll test for. How do they test it? They do the sweat chloride test. Now, they also have those metabolic, those little circles that we do. It also can show that also. One of the outcomes or long-term things with cystic fibrosis is because it affects the pancreas and the pancreatase and the enzymes that it can cause diabetes as they get older. So it is a comorbidity with cystic fibrosis. When you have a child who's older, these children should know how to care for themselves. They should know how to put the vest on, to give CPT, to give aerosols. They really need to be in control of themselves. Now, what do you see with cystic fibrosis? Well, we have upper respiratory mucus, and we have a pancreas that doesn't secrete what it needs, and you lose fat vitamins, and you're, not absorbing fats, and your stools are the worst smelling things I've ever smelled. They are bulky, oily, because the grease is coming out that way, foul smelling. It's also called steatorrhea. But again, all those vitamins are coming out. So these children will need some sort of vitamin supplements. They also, because they're not absorbing fat, they need high protein. They need high carbohydrates because this will help them keep their weight on, so not have weight loss. Because of all the mucus in their lungs, they'll have wheezing, rhonchi, dyspnea, and it's a dry, non-productive cough. I mean, these children will require albuterol treatments every morning and maybe every 4 or 6 hours during the day, depending. And, they put these vests on. You see these two pictures, those are things that vibrate, and it's like chest PT. And one of the complications of cystic fibrosis is chronic infections in the lungs because they're like big petri dishes. They get bacteria in there and they grow, and it creates, a lot of pneumonias because of it. Now, one of the things I said is that they do need extra protein, they do need extra carbohydrates, but they also need salt. What does a sweat chloride test monitor? It monitors how much sodium is secreted onto the skin. That's salt. So they're losing it like crazy, okay? Also, as I said, they're going to have some sort of vitamin supplements going on. They're going to need something to keep those lungs from being thick and clogged and sticky and not getting it out. They can't breathe. It needs to be loosed. So they need mucus thinning medications, just sometimes saline, bronchodilators. And we know that if you're going to give CPT to these children, give them the bronchodilator first, right? You open the lungs, CPT, and they can expectorate this thick mucus. And azithromycin is the most common of all antibiotics that is given to children of cystic fibrosis with pulmonary infections. One thing that we need to teach is making sure that they do daily cleansing of their respiratory equipment. We're doing CPT and we're giving aerosols. They're coughing, they're spewing mucus into these masks, and we need to make sure that they clean. Soap and water is fine, but they need to clean it every day. Another thing for their diet, so that we can at least try to get some of these diets in us, these that we give the pancreatase enzymes so that it can break down the food and we can get some of that possible nutrition from it. So there are some things to know about it. Now, we do not crush or chew anything enteric. Those little capsules, those beads, you can't crunch. You can put it in, now I've always said you can't put it in food. You definitely not in a bottle, but you could put it on a little teaspoon of food and give it that way to get it in, and it should be immediately before they eat. Also, there's a powder. And if you're going to use the powder, they need to rinse their mouth out when they're done. Because just like some of the inhalers like Symbicort, Brio, Advair, they do hurt the teeth enamel. This will too, the powder from this. So they need to rinse it out. And we always forget that we need to increase their enzymes as they get bigger. It's one of the things that they could grow 5, 6 pounds in a year. I mean, that would be the most ideal for this child, but we need to increase what we're giving them in the pancreatase so they're getting enough of it. Now, one of the things with cystic fibrosis is fertility. Now, females can get pregnant. Yes, they are a high risk pregnancy. Males have mucus clogging their vas deferens, which means the sperm can't get to the woman. But once a male does a double lung transplant 1 year later, then all of a sudden he can deliver his sperm and he can have a child. So that's one of the things with cystic fibrosis. Now, most common of all surgeries are tonsils, adenoids, and tubes, right? So let's go with those post-tonsillectomy care. Now, what they do is you see those big round balls, they cut them off and cauterize them. And there's 2 scabs that are left there. Basically, there are no stitches, they're cauterized scabs. So remember that. No irritating or highly seasoned foods. It'll burn. It doesn't feel well. You don't want them up and running and jumping and going crazy because then they'll start breathing and then it could get these scabs off. And let me tell you, they will bleed. I had one child 7 days post-op go into hemovolemic shock from the amount of blood and clots she was throwing up. And we had to resuscitate her. I had to take her back to the trauma room, get an IV in her, put a lot of fluids, got her up to the OR, and they had to recauterize the area. So it is a big deal. They need fluids. They need to keep those fluids going always. Kids don't always like the ice collars, the young ones. Too cold, it's too cold. But older kids, put a nice ice collar on. Give the younger kid a popsicle. Who doesn't like a popsicle, right? Young kids, but don't give them red ones because you want to see are they bleeding or not. Or whatever cold thing they like, give to them. Ice, whatever they like. If you're seeing bleeding after post-op day 4, or you start see have smelling after day 7, these are things that should be reported. One of the things that we need to tell the child is they're going to have a sore throat when it's done, but it will go away. And as they start, he'll come home from the hospital and they're there and they all of a sudden you're looking at them and they're sitting there and they're swallowing, swallowing, swallowing. This is probably bleeding. So it would be a clue. We need to get this kid to the doctor. Now, you don't want to put anything in the mouth. You don't want to look at it, but just a little bit of a tongue, you would see blood on it and you would know it. Older kids get a lot of ear pains, and how they get rid of it is like equalizing their ears like on an airplane. Chew gum. And it does open up those eustachian tubes. And remember, sometimes loose teeth can be an aspiration risk on these kids. And what about school age kids? They're all losing teeth, right? So be aware if they have loose teeth. Now, as I said, croup was expiratory, right? Inspiratory. It's all about upper airways swelling up, can't get air in. Asthma is way down in the lower alveoli. It gets swollen. So you get air in, but it gets stuck and it can't come out. So it is expiratory wheezing, okay? It is a cough that gets worse and worse, and then you start hearing that wheezing. So some things we have to tell our parents is, we need to know what are those things that make our bronchus so hyper responsive. There usually are some allergies involved. For instance, if they're allergic to grass, don't have them in the grass. I mean, I know up in New York when I used to live there, raking the leaves up used to give me even wheezing. So I'd be careful with them. What about flowers? The smells, all of these things could create problems. Cats, dogs, all of those things. Those children shouldn't be around them because all it's going to do is precipitate an asthma attack. So what do you see? Frequent cough, getting very short of breath with minimal exertion, that wheezing, and remember, it's expiratory. And you hear like, when you breathe out, or sometimes the lungs, you just hear a little squeak like and that's it. I mean, it gets stuck hard. So absence of wheezing, no air is moving, okay? This is an apneic child, most likely alert initially, and then they'll go unconscious. So absence of wheezing is an emergency. As I said, the expiratory phase is really prolonged, and in a preliminary things that we see, these children are given that peak flow meter, and they should be testing themselves every morning. They've gotten a good result from when they've been feeling well, and they know what their number is. They'll start seeing it decrease, and then all of a sudden they go into asthma attack. I mean, and if they see that, what they should be doing is start albuterol aerosols, get it going, get it moving. And again, that wheezing is a high priority if you don't hear it. So we give albuterol, it's our rescue, right? One of the things we should use in children is that spacer. That makes sure that they get all what they need. I mean, that upper picture is what that expiratory meter is. We can see, what's going on by just that breathing every morning. Remember, you breathe better when you're sitting up. That makes sense, right? They're laying down, have them sit up, and it will help. Corticosteroids, we do in asthma children give an BID medicine morning and night. Usually Pulmicort's the name that we use. It is like that Symbicort that we use in adults, but it is something we give children, has a little bit of steroids in it. It's only to prevent attacks. It's not like steroids, like taking prednisone, but it's very little there, okay? One of the things with asthma children is to keep their lungs working, so that these children keep their lungs breathing. Swimming is a great thing, right? There's no allergens around. You have to hold your breath, go underneath, and it really, really helps. So croup, we went to a little bit before, what it was. As I said, it's inspiratory, but remember, it's all upper more. And what is our goal with these things? Now, one of the things that you see with croup is abdominal breathing. And why do they start abdominal breathing? It's because they'll breathe easier. It's more efficient for them. So usually children, the younger children, you might see that, but as they get older, you shouldn't. So if you're seeing that, that's a problem. Another thing with croup is we've treated them. Usually we'll either give them a PO or an IM dose of a steroid, or they're given a couple doses prednisolone. Take 3-4 days at home. Now, remember, croup is the larynx. The epiglottis is covering the larynx. It's swollen a little bit. That's what's causing this noise. So if you get home and now this child can't swallow secretions, remember, croup turns into epiglottitis. All right. So that is your key clue to get in for treatment. So what is our treatment just for regular croup? Well, what we do is keep the airway open. We're going to maintain hydration. Some of the kids can drink, some of them can't. That would be IV. That mist with O2 really helps. That moisture helps. And we give epinephrine in an aerosol, and it goes directly to the larynx, where is all that swelling is coming from. And of course, we'll give IV or PO steroids. As I said, croup on, if left untreated, will lead to epiglottitis. This is a medical emergency. The epiglottis is covering the trachea. There's no air that can go in. What do you see? What's this kid look like? Well, this kid is usually can't talk, or it's this garbled frog-like talk. They are drooling, they can't swallow secretions, and they're usually leaning forward, trying to find a place where that little larynx has got a little space to breathe out of. And it's really a scary thing. These kids are irritable, they get restless, they're becoming hypoxic. So we need to have these kids calm down as much as possible. So wherever they're sitting, they're happy, leave them there. They don't have to go sit on the stretcher. They're on a chair next to where you want to be. On mom, I leave them there. As I said, immunizations, how you can prevent them. The Haemophilus influenza can help prevent epiglottitis. So again, that's why the immunization status is important, keeping them up to date. So epiglottitis is a respiratory emergency. You should never look into their throat. You're not going to see it anyway, as you know, we need like a, to look in there with, the thing to intubate. And we're not going to do that. So only people who are going to intubate, if they need to, should look because it causes more swelling. No putting tongue depressors, nothing in there. And you need to have this child next to where an intubation or tracheostomy tray is. Because if they need a quick trach, we can do it, or intubate. They don't have time to wait. Now, RSV, you can see the difference between infants, children, and adults. RSV for me and you is a common cold. RSV for a kid, they don't feel too great, but it's still an upper respiratory. Infants, they need to suck, swallow, and breathe. And then you put secretions in their nose, and they're obligatory nose breathers. They can't breathe. So now they are struggling to eat. They're irritable because they're getting hypoxic. They're getting periods of apnea because now they have fever, they can't breathe. So what do we do for this? Well, RSV is also bronchiolitis. It's the same name. They call them the same thing. It is a virus. The secretions are thin and they do have fevers. Not big fevers, but they do have enough to make them feel bad, really bad. In children, you're going to see all the signs and symptoms of respiratory problems. You'll see nasal flaring, grunting in younger infants that are not doing well at all, okay? And you're going to hear junk in the lungs. It's just a lot of mucus, as I said. It does go from child to child, child to nurse, so be very careful about that. So if you're worried, put a mask on, wash your hands. Now, what if your kid is cystic fibrotic? Also, has a cardiac disease, have all these other things, immunosuppressed. They need to take a Synagist injection, and it's once a month. Always try to avoid sick people, but we know we can't all the time, right? And one of the things that we do use for these children, especially admitted, is this mist tent. It's this big plastic sheet that goes over like the top of a bed. And they put in this moist air. Sometimes, and it's cool, and sometimes these children don't want to be in there. It's okay if the parents need to hold them and just have that mist blowing in their face. That also will work too. Sometimes I see parents get in the bed with them, but they also can have them, with the mist going on them. Now, pneumonia, there's all sorts of pneumonia, right? Aspiration has to do with feeding, making sure we're burping, not overfeeding, sitting, having to sit up afterwards. And then remember, aspiration is also breathing in chemicals or powder, and also no smoking around young children. With viral infections, all we do is acetaminophen, ibuprofen, fluids, and rest. That's what we call supportive, all right? In bacterial, we're going to be giving antibiotics. Now, oral pharyngeal up here, sort of infections, which will drip into the lungs, are usually staph, right? This is all staph up here. So augmentin, it's a great drug of choice. Again, antipyretics, fluids, rest, but this one will be given antibiotics. Mononucleosis is the kissing disease. It is a virus. It's called the Epstein-Barr virus. Epstein-Barr is known for making you really tired and you don't feel good and you might have some swollen glands. In mono, you see that sore throat, um, and you see a swollen spleen or liver, and they're tired, fever, they get rashes. And one of the things that we need to be really aware of and teach our parents about is that those spleens is like a big baseball or basketball full, and it's like a balloon. And if it gets hit, it can rupture, and these children can die. I saw it. My eyes, I've seen it happen to a young child that I took care of, that I taught. I taught the father, I taught the child. He came back a week later. He was out on an ATV after being diagnosed with mononucleosis. We tell them no participation in contact sports, no PE for 3 weeks or until you get cleared by your physician. Treatment is a virus. So it's ibuprofen, acetaminophen, fluids, and rest, rest, rest. And it usually by itself takes care of itself. Now, congenital heart defects. I know this is an area which is difficult for many students. So let's just look at what you see and when things are wrong. You're not always aware that there's a congenital defect at birth. They've got these great ultrasounds today, but they don't always have all the answers. So what are you going to see? A rapid heart rate. Heart has to beat quicker because it's not oxygenating the way it should. You're breathing faster to get more oxygen around. You're not pumping your heart as good, so you're having swelling, legs, abdomen, eyes. You don't have any energy because you don't have oxygen and your heart's beating so fast and you have all this extra fluid, you can't move, right? And you're starting to swell. Then all of a sudden you see this weight gain. Like all of a sudden these children are up 1 pound. 1 pound on an 8 pound child is a lot of weight. They should be losing initially after birth. Or you're going to see these children will not gain weight because they tire out, they cannot eat, and they are, not getting all of the nutrition that they do need. Sometimes you see a bluish tinge, but not always. Remember, there are cyanotic where, yes, their oxygen saturations are lower than normal, but many of them are absolutely normal. So what would you do with a child that is congenital that, you still need to get nutrition in them? Well, it should be small, frequent feedings, not just big feedings every 4 hours. These kids might eat every 2 hours because they're tiring out. Some of the things we can do is increase the calories. We can put breast milk fortifier if we need to get calories in these children. And we do have formulas up to 30 calories per ounce, and the normal is 20. So that's pretty, a lot more calories. And then limit those feedings. Please don't overfeed these children because you're just tiring them out and you're just burning the calories, so it doesn't matter. These children are also going to have murmurs, or it's just going to sound different. Sometimes I can even feel the sensation on their chest without even listening. And then we talked about coarctation, which is pulses different. That's why cardiac children get 4 extremity blood pressures, even if they're coarctation, even if they're not, because this is what we see. Sometimes it's stronger on the right than left, preductal, postductal, but I'm not going to get into what all that means. Congenital defects. Now, I said acyanotic, cyanotic. This is right out of your book. Now, increased pulmonary blood flow. I talked about shunting. Blood likes to go in holes that shouldn't be there. Where there's high pressure, it goes to the low pressure. Just like in the throat, you have all this gook in your throat. Where does all this gook and mucus escape to? Poof, into the ears. That's why clearing that mucus is important. Well, pulmonary blood flow, left side is pretty strong. The right side, remember, that blood just gets back there. That's the end of where it comes from. Comes out the aorta through the body and it just gets back. So why increase pulmonary blood flow? For a hole, a septum hole, an atrial septal defect. There's a hole between the right and the left atrium. The blood from the left side, woof, back to the right side. And then it goes back in the lungs. So that's why increased pulmonary blood flow. Same thing with the ventricle. Comes to the left ventricle instead of going to the body. Whoop, let me go back to the right side, back into the lungs. And then patent ductus arteriosus. That's the thing that's open at birth that closes, right? It connects the lungs to the body. So the body squirts out off the aortic arch and it goes up into the lungs because it's pulmonary artery to the aorta. So again, increased pulmonary blood flow. Coarctation, remember, there is a difference between upper and lower extremities. There's a kink in the hose going down to the body. So pulses in the feet are going to be decreased. Your blood pressures are going to be decreased. They're going to be elevated in the upper extremities. And any osis means it's a narrowing. That means that this child is not getting all the blood to the body, the aortic, or not all to the lungs, pulmonic stenosis. Tetralogy is the most common of all of the diagnoses that all of your exams love to talk about. It's when the pulmonary artery gets blocked, occluded, and blood can't go to the lungs. So you went from an O2 saturations of 100, all of a sudden it's 10. This is your TET spell. This is the blue cyanotic spell, okay? We do what to open that up? We do simply a knee chest. And in younger children, what that does, it changes the pressure in the abdominal cavity and the chest cavity. And it somehow, doing that knee chest, pops open whatever is occluding that pulmonary artery and blood flows. Remember, atresia is there is no opening. So you need to know where the tricuspid valve is. It's between the right and the left atrium and ventricle. That means blood don't go from the right atrium. It can't get into the ventricle, so it can't go to the lungs. So that's an important concept there. And transposition is just the pulmonary artery and the aorta are switched. So you have pulmonic flow going around and you have systemic flow going around, and they're not meeting each other. So this child needs that PDA to stay alive because it connects the lungs to the body. And that's the way they live actually for about the first week of life until they do that arterial switch operation and change it. So tetralogy of Fallot, again, is 4 different types of heart defects. There is a hole between the ventricles called a VSD, a ventricular septal defect. That pulmonic valve, there's a stenosis or something that creates it that it just doesn't have an opening for blood to flow up there. The aorta, I think because of the VSD, is pushed over, so they call it an overriding aorta. And sometimes when that pulmonic valve gets stuck, blood can't go to the lungs, so that right ventricle gets stretched a little bit until it can go up. And that's what the hypertrophy means. It's a stretching. So again, these are TET spells, blue spells that would happen. If the kid is older, even younger, just calm them down, give them a pacifier. It relaxes them. Morphine, digoxin, and of course that knee chest can help, okay? So that patent ductus arteriosus. So we know that it connects the body to the lungs, very simply. And for instance, in that transposition of great arteries, how are you going to get blood flow, with oxygen to the body? Well, we need that little tube there open. So we know at birth, mommy stops secreting the hormone prostaglandins, which keeps it open when the baby's inside the mother. The baby's born and it stops producing it, but we can give a synthetic one called prostaglandins E1. And what does prostaglandins do? Well, the first thing, of course, it increases oxygen saturation. And what that does, it allows that heart to pump as effectively and efficiently. It's getting its oxygen and it keeps blood going to the brain. So we keep that central nervous system doing well. Now, sometimes, especially in your younger, premature infants, mostly, not all the time, but mostly, it doesn't close. And we know that that's the case where we need to do something to close it. You're going to hear a machine-like murmurs, like a washer machine murmur on it. And we can give a medicine called indomethacin. And it's a 3-dose thing. And we can listen to that murmur stop and it will go away and that will close it. Like I said, atresia is nothing. Nothing's opening. And you see the picture there? That is a tricuspid atresia. There is no blood flow going to the lungs. Now, stenosis, and a lot of times you'll see that in aortic stenosis. That means blood isn't getting to the body as well as it should. So if you're not getting all the oxygen and nutrients to the body, you're going to tire quicker, right? Those are things you're going to see. Chest tubes, just like pain. These are things that please medicate them, explain it to them on their level, be honest with them. It's gonna hurt. I worked with adults. It hurts, it burns, but it's like 20 seconds maybe. And they say, oh, okay, it's better already. Even being given medications prior to pulling tubes. Always document vital signs before and after because you're going to give a narcotic with it, okay? And always those chest tube site areas, we don't put lotion and anything on them. We usually just put a Band-Aid on them, a steri strip on them, just keep them clean. There's doing a lot of things to keep more like plastic things so they don't have all of these marks on their chest. Transplant, greatest risk is rejection. It is not infection. It is rejection. Digoxin. Now, why do we mention digoxin when we're talking about children? One of the most common of all the drugs we use in children is digoxin and furosemide. Those two, common. And we know digoxin slows down and strengthens the force of contraction, and it helps with children that have problems with the heart pumping, especially when you see heart failure. So, how do we take care of giving a child now, especially an infant? How do we know an infant is not in digitoxicity? Well, you're going to check the heart rate just like you do adults. If it's below 70 in a child, below 90 in an infant, that's too low. We know in the initial neonatal stage, heart rate's 140 to 160. 90 is bradycardia for these children. Also, as they go home, they need to give it 1 hour before or 2 hours after meals so that they're getting their dose, okay? Because remember, sometimes there's reflux with feeds and we want them to get it. And same time every day. Usually it's that 10 a.m. dose that we give, right? So before we check it, has the kid been vomiting? This is in your infants, the one thing you might see. Everything else might look good. You're going to check the potassium level. You're going to be checking digoxin level. You're going to be looking at heart rate, and vomiting is the other one. So what do you do? Even if the kid just starts vomiting, who never vomited, I'm going to hold it. I'm going to call the doctor and I'm going to do a dig level. So cardiac cath, they put big catheters in the right femoral artery and femoral vein. And when they take it out, they hold pressure and put a pressure dressing and maybe a sandbag on it on older kids. Now, first thing I check on any kids, because they've gone from the cath room back to me and there's been some bouncing down the halls, et cetera, going on. And sometimes the clot that's been on, those femoral artery and vein pop off, and these children are bleeding. Number one, check for bleeding. If they're bleeding, you take 2 fingers and you put it above push pressure and call for help. All right. But first of all, stop the bleeding, because an infant can bleed out pretty quick. And a lot of your congenital heart defects are infants. Okay. Take vital signs and watch, blood pressures. You're going to keep that right leg straight, no bending. You don't want to do anything to create that clot to come off. And they need to stay in bed for 24 hours. Another thing is to make sure that they are eating or drinking, because they've gotten some dyes. They just wanted them to urinate it out. It doesn't hurt them at all. And we're going to check a glucose. Young children especially need something every 2 to 3 hours because their glucose levels drop. So making sure that they're at a normal level when they come is what we need to do. Now, rheumatic fever. This is one of 2 diseases caused by an inadequately treated strep throat. What do you see? Well, the kid's going to have a fever. It's going to have joint pain. It's going to have a rash. He's going to just have these joint nodules. And then he get these weird movements called chorea. The one thing that cannot be reversed with antibiotic is the heart valve damage, usually your mitral valve. You cannot stop that damage. Once it's there, it's going to need medical or surgical repair. How do we treat it? Well, long course of antibiotics. I mean, even that weird central nervous system chorea will go away, but the heart valve, no. All right, some of the things from this week. ITP, idiopathic thrombocytopenia purpura. P for platelets. Platelets are low. Why? Well, sometimes they've had a little viral something, upper respiratory, like within 3 weeks. And they come in and they've got breathing or bleeding or bruising, nosebleeds, you might see. And parents are like, well, this kid doesn't go anywhere, doesn't do anything. And why is he bruising? Why does he have these petechiae everywhere? It's one of the clues. So we do a CBC and we look at the platelets, and the platelets will be below 20,000. So low platelets causes bleeding. It's one of the things you need to prevent bleeding. So thrombocytopenia means low platelets. Okay. You'll see that easy bruising, even in the mouth. And these children need to get on something to help them. Now, it was due to a viral something, I said, remember? So we just give supportive, but IVIG will be given, the IV immunoglobulins and something called anti-D antibody. And it usually by itself just straightens itself out. Now, if these children are admitted to a hospital, there are certain things that we need to do. They need to be placed on bleeding precautions. They need to, you need to be watching them for bleeding, urine, stool, gums, as minimal possible, no needles, no venopunctures. Usually we'll even draw laboratory work off of existing IVs because we don't want to puncture them again because they'll just bleed. Their platelets are so low. And because we're monitoring them closer in a hospital, we'll be monitoring those platelet counts, so monitoring those blood counts. And then sometimes we need to give corticosteroids on these children. Now, the types of anemia. Now, iron deficient anemia means there's not enough iron in the blood. It is usually due to a dietary problem. Sometimes we can treat them with just diet. Sometimes we need to give them, increase their diet. Eggs, whole grain, raisins actually are some good sources of iron for them. We can give them a Z-Track, deep iron, dextran injections for those children, or maybe don't want that by mouth, the iron. Remember, if any person takes iron by mouth, they need to take it with orange juice. And the reason is is iron is digested, broken down in the stomach. And that orange juice, that acid in it, helps it digest more. And iron can stain teeth, so give them a straw. So please get it through, their teeth, and it will go down without staining their teeth. They say toddlers who drink whole milk, so they're not on formulas anymore because we're not giving them iron that way anymore. And of course, we know toddlers are picky eaters, right? Those are the highest risk children for iron deficient anemia. Now, megaplastic anemia is all about absorption of B12. One of the things and easiest way you can check is have them stick their tongue out. Their tongue is sore and it's beefy red in color with megaplastic anemia, which is, the B12, the intrinsic factors missing. Hemolytic anemia is when sometimes you have things that cause the cell to burst. I know the GP, G6 thing, children with sugar, it causes their blood cells to burst. One mother one time told me that the kid had that, and I'm like, I don't know what that is. And she says, well, he can't take regular ibuprofen or acetaminophen. So I had to get some sugar-free stuff from the pharmacy. Sickle cell is your sickle-shaped cells. We'll go into that a little bit more. It is, again, an inherited trait. Cooley's anemia. This is that fourth stage of thalassemia. It is from Mediterranean history. It is where the cells die quickly and they spew iron and oxygen into the blood. And because of that iron going out, they are going to need some sort of something to get rid of that iron. It could be an iron chelation drug therapy, or it could be a thing that sort of resembles dialysis, but it's called apheresis. These children have to have blood transfusions to live because their cells are dead. They just die very quickly. So they would prefer that. A lot of times they do splenectomies on those children because they don't want them even to produce cells because the cells are creating more problems with the iron. And aplastic anemia is all types of cells, white cells, red cells, and platelets have a problem. So sickle cell, inherited. Both traits is, again, 25% chance that this child can also get it. Your diagnosis for these children, so if a patient experience a vaso-occlusive crisis, is in pain, and it's due to that vascular inflammation from that sickle cell. So what is our priority nursing action? Well, everybody says pain medicine. No, you're treating what the symptom is. What you need to do is what is the cause of sickle cell? And that's how the cells sort of occlude on each other and blood can't go down because the vessels are too small. You need to start IV hydration, number one. That's number one. I'm not saying not to have pain medicine in the other hand, but get that fluid going. Keep them hydrated normally. These children also need to eat high in protein and calories, carbohydrates. Another thing is traveling in a plane causes that pressure. Those vessels constrict, right? Have them drink a lot of extra fluids. It's a problem. These kids also should exercise. Just because they have sickle cell doesn't mean they can't. And taking that pain medicine before it's too bad. And they do need good rest periods. And if they're out exercising, make sure they have something to drink right next to them. Now, HIV in children. We know it can be caused from mom giving it to the child. We know that there's a couple things they can get, and you can see those things, Candida esophagitis, or they can have the pneumocystic pneumonia. And depending what it is the treatment. Respiratory, pneumocystic pneumonia, again, it creates a lot of respiratory issues in children because with HIV, they don't have an immune system, right? So what is our focus? What do we need to do for an infant born from an HIV mother? Well, we need to improve that infant's immune function. And we know that mothers, if they can, should be on some sort of antiretroviral therapy at 22 weeks of pregnancy onwards to help the baby. But if not, they also need it at birth. They need to be getting these antiviral drugs. Remember, it is a virus. We need to take care of it. We need to give good nutritional support. I mean, that is, absolute with any child here. And as I said, I've seen triplets born. One had AIDS, one had HIV, one had nothing, was completely clean. So you don't know what's going to work or not. I've seen children by the age of 1 seroconvert and not be HIV with proper treatment. So it does work. So improve the infant's immune system and prevent those opportunistic infections. Anybody who gets anything, blood, antibiotics, and there's a reaction going on, number one, stop it. Just stop the infusion. Um, when you see those short of breath, those veins coming out and cough, that is absolutely a circulatory overload. Maybe it went in too quick. I mean, today we're lucky. We've got all of these special pumps that work. I didn't have them when I first started nursing, so I think it's great. Osteosarcoma is a cancer of the long bones. Many a times it's the femur bone. So we need to take the whole bone out in this case. You can't just take off the tumor. You got to take the whole thing, got to take it out. So what we do is take the lower leg and reattach it. That's called salvaging the limb. And it helps because then they could put a prosthesis on. And then these children can walk more easily. If you don't have a place to stick a prosthesis, to be able to move, these kids are not going to be as mobile. Leukemia is your white blood cells. White blood cells just aren't, they're being made, but they're all immature. And these children are come in and we diagnose them, do blood smears, we find it. They come in pain, they come in with fever, they come in with bruising, and they do the smear, they do the white count, and they see it's very low, and they see the cancer cells. What do? Well, we're going to be putting in some sort of permanent IV access. Usually a port is what we do. And what we do is there's stages of chemotherapy treatment. But the first stage is called the induction stage. And that induction stage is they hit these children, even the adults, with many different types of chemo. Could be 2, could be 3 types. And in the first 4 to 6 weeks, they want to knock out the cancer. And they do. They put them, our goal is remission, and we get them there. But then they start with other things to put in the central nervous system, and then to find any other little cells and prophylactically to kill any hiding cancer cells so it doesn't come back. And we know chemo does cause vomiting, and to give them something before you start the chemo, prevent it. One of the things with leukemia, sometimes these children are resistant to care, and some of them need a bone marrow transplant. Now, if we're lucky enough to have the money enough to be able to save the baby's cord blood, that is automatically the best, autologous, the best. My own blood is the best to give me. But if you can't give a bone marrow that's your own, because many people don't have that, it's allogenic, means all the other people, as I call it. So automatically mine is the autologous, is the best. Allogenic, all the other people, we know that a sibling is actually the best allogenic. And one of the big complications of any bone marrow, again, is that infection of it, and they do get donor host sort of rejection there. Now, with chemo, one of the things we do is we destroy cells. but we only don't destroy cancer cells. So a lot of these children, they have no white counts, right? And what they measure in infection is neutrophil counts. Neutrophil counts are 1,000, 2,000, normal. Now, if you see a child, now most of these neutrophil counts that are low are chemo children. But what if you have a child in septic shock or impending septic shock? These children's neutrophil count will be below 500 too. These are your priorities. These children have no immune system. They get an infection, and especially if they're running a fever, these children need antibiotics because they have nothing to fight. So there's two sorts of lymphomas, and there are Hodgkin's and non-Hodgkin's. Now, Hodgkin's is from the shoulders up, and Hodgkin's are big lymph nodes that are painless. Sometimes they get big and it crushes the throat, so that's why the cough. And they're going to do just a little biopsy, find the Sternberg Reed cells, and we'll give them chemo. Non-Hodgkin's are lymph nodes, just little tiny scattered diffuse. You don't see it. All right. So Hodgkin's, you see them, the enlarged, shoulders up, the neck. Non-Hodgkin's is all over, but it's diffuse. It's sporadic everywhere. Brain tumors. One of the things about brain tumors is children who start to have changes of behavior or having headaches that are getting worse that can wake them up at night, or vomiting that is not related to feeding. This is one that we're being concerned that there's a brain tumor. Many times they do radiation to shrink them so they don't have to take out a big piece of their brain. So if they put those little blue or purple marks on their head where it's at, don't ever take them off. They need it for the next treatment. And Wilms tumor, it is a renal tumor. It's on the kidney. It is very fragile. And if you touch it a lot, pieces will break off and it will metastasize. So put a big sign somewhere. Do not palpate the abdomen. They don't even do biopsies on these, okay? Because again, putting a hole in it is releasing metastasis. We treat it chemo, radiation, one or the other or both, and surgical removal. They do well. In CPR, it's something that you should always review. We know that if you see them, you do your 1 to 2 minutes of care, then call the 911. So you start chest compressions, 2 breaths, 911, and then you keep going. That's one of your algorithms for it. So there are 5 simple dose calculations, nothing different that you didn't see last test. And here's the 3 Kahoots that I have. I believe all your professors have posted that. If not, you let me know and I'll send them to you. I wish you luck. A lot of stuff, but I think you'll do okay. Any questions? Thanks for your patience. Good luck to you guys. You are welcome.